Priyanka, I will upload the slide. Yeah.
Okay, doctor. Mukesh ji, any update from Dr. Kasliwal here?
Good evening, Dr. Parikh sir.
Yes, namaskar, namaskar. कैसे हो?
Good evening, Dr. Ambit sir.
Yes, yes, Kanna साहब नमस्कार.
Good evening, sir.
कैसे हैं dear?
Thanks, sir.
Sir, we will start in couple of minutes, sir.
हाँ, अभी
Good evening, Dr. Ambit.
आपको
Yes, sir.
Good evening, everyone.
मुंबई में? Good evening. Dr. Amrish?
Good evening, sir.
हो रहा है आपकी तरफ भी बॉम्बे में?
Sir, so far 300 people have already joined with us. So it's going to be a big show, I think so.
Sir, you were saying something. We couldn't hear you, so you said something. It was not audible. Dr. Parikh sir, did you say something, sir?
हाँ जी.
सर आप कुछ कह रहे थे अभी सर.
जी क्या बोले?
सर अभी आप कुछ कह रहे थे सर. कुछ अजान की आवाज आ रही थी.
आप मुंबई में हो? कहाँ हो? जयपुर में हो?
नहीं, no sir, I am at Noida sir, Delhi.
हाँ तो ठंड कुछ वो कोरोना का प्रकोप कम हो रहा है उधर?
सर बहुत कम हो गया है. Started to go to office. अब तो बहुत कम हो गया सर.
अरे वाह.
Cases are very less now.
इंडिया ही कम हो गया.
So you had your vaccine? You took your vaccine?
वैक्सीन एक्चुअली हैदराबाद में मैं कोशिश करूंगा कि यहाँ लग जाए.
Okay, sir.
दिल्ली में सेरो सर्वेलेंस में 56% आ गया है अभी परसेंटेज. दिल्ली का जो सेरो सर्वेलेंस करा है, द इम्यूनिटी हैज कम टू अराउंड 56%.
बहुत बढ़िया. हर्ड इम्यूनिटी की तरफ जा रहा है. चलिए बहुत दुख दिया पर यार इसने बहुत जाने ले ली.
Correct.
वेरी अनफॉर्चुनेट. वो टाइम चले गए ना, उनका बहुत दुख है इसकी वजह से.
Almost 1 year. Means a lot of impact on the businesses as well.
वो तो लाइफ भी बहुत गई. डॉक्टर्स भी गए और दूसरे लोग भी गए और पूरा दुनिया थम गई एक उस पर एक यूएसए जैसी कंट्री हिल गई पूरी तरह.
सभी लोग और across the globe.
हाँ नहीं पर they were considered to be very strong country to deal with every problem that comes in their
Right.
And they could not. I think we did better than them. I do not know whether how it worked everything, but very fortunate to have the outcome from the corona, whether it is a death or recovery or total rate of involvement of corona infection.
Right. So, sir, the flow of the meeting, Dr. Parikh sir and Dr. Amrish sir, I will start and I will introduce Dr. Amrish sir and then hand over to Dr. Amrish sir for the introductory remarks. And after that, I will introduce Dr. Parikh sir and I will request Dr. Parikh sir to share his initial thoughts about this webinar. Then I will start my session about the OSMO technology. This will be followed by after 10 minutes. It will be followed by Dr. Kasliwal's session on on metformin challenges in clinical practice, and then Dr. Ambrish sir will share his own clinical experience for the usage of these products, as he was the part of the OSMO safe study. And after that, sir, we will have the
That's good. But I think in the program, I was to introduce, just give a introductory remark.
yes, sir.
And then Dr. Ambrish,
Yes, sir.
and Dr. I mean, how it will start, the flow of webinar.
Sir, first, I will start. I will introduce both of you, and then both of you can give the opening remarks about this webinar, and then I will start my session about the OSMO technology, sir.
Yes. So after uh, I'll give an introductory remark for 2 minutes. Then Dr. Ambrish will speak, give an introductory remark for 5 or 7 minutes, whatever he.
Yes, sir.
So that will
Yes,
be.
sir. Priyanka, just confirm when we can start the meeting.
Yeah. I'm just checking Mukesh. Give me 1 second.
I think more than 420 people have already joined.
Yes. Dr. Shah, I just got an update from Mukesh. So I think sir has got free. He is just joining in 2-3 minutes.
Okay. Good evening, Dr. Rajeev, sir.
Good evening, everyone. Good evening,
evening,
Parik
sir.
sir. Sorry for keeping you wait.
Hello, sir. Good evening, sir.
Shall we start, sir?
Yeah, please.
Okay.
Sorry.
Dr. Parikh sir, Amrish sir, we can start?
Yes.
Okay, thank you. Good evening, everyone. Greetings from WOCAD. I am Dr. Shahu Ingole, Head of Medical Affairs for WOCAD Pharmaceuticals. On behalf of WOCAD Metabolics team, WOCAD Diabetes team, and WOCAD Medical Affairs team, I welcome all of you for today's mega webinar on the OSMO laser technology, which has been researched for the first time in India by WOCAD. What's there for me in the diabetes clinical practice? And for this mega OSMO webinar on OSMO technology, we are honored to have with us a esteemed panel of diabetologists across India, Dr. Amrish Chandrapasar from Bangalore, Dr. K.K. Parikh sir from Kota, Rajasthan, and Dr. Rajiv Kasliwal sir from Jaipur. So on behalf of WOCAD, I welcome all of you, sir, for and thank you for sparing your valuable time from the busy schedule for this OSMO webinar. We all know Dr. K.K. Parikh sir. Sir is the senior consultant physician, Kota, Rajasthan. Sir is the president-elect Indian Association of the Clinical Medicine. Sir has been the past president Association of Physicians of India last year. Sir has also been the past chairman Scientific Committee Association of Physicians in India, Epicon 2019, Kochi. Sir has been the past dean Indian College of Physicians. Sir is the founder, President, Research Society for the Study of Diabetes in India, Rajasthan chapter. Sir is also the organizing chairman, National Conference of Research Society for the Study of Diabetes in India, 2019. Sir has been organizing chairman, National Conference of Association of Physicians India, APCON 2021, and chairman and senior consultant, SN Parikh Memorial Hospital, Kota, Rajasthan. So I welcome Dr. K.K. Parikh sir and request Dr. K.K. Parikh sir to give the introductory remarks regarding this OSMO WOW webinar. Over to you, sir.
Yes. Thank you, Dr. Ingole, for kind introduction. And good evening, everyone. It's a great pleasure and a proud privilege in welcoming all of you to this very important webinar on OSMO laser technology organized by WOCAD. It is also a great opportunity for me to welcome our learned and eminent speakers for today's webinar, Dr. Rajiv Kasliwal from Jaipur, Dr. Amrish from Bangalore, and Dr. Sau Ingole. At the outset, I extend my sincere thanks to the management of WOCAD for giving me this opportunity to be a part of this very important seminar, CME. Diabetes, we know that it is a chronic disease, and the adherence to antibiotic drugs is very crucial for the better outcome of the treatment. But unfortunately, only 30% of type 2 diabetes patients adhere to the anti-diabetic therapy. We know that non-adherence to drugs in diabetes increases the morbidity and mortality to a great extent because of its vascular complications. There are many reasons for the non-adherence of drugs in diabetes, but one of the few of the most important reasons are frequent dosing because of the associated comorbidities with diabetes, size of tablets, more number of tablets, then short duration of action. So these are the reasons, common reasons for non-adherence of anti-diabetic therapy. And because of these pharmacokinetic limitations, recently there has been a focus on controlled drug delivery system and especially on osmotic controlled release oral formulations. OSMO technology is very promising for controlled drug delivery of drugs to enhance the greater bioavailability of the drugs and longer duration of action, and especially what is more important, to keep glycemic control time in range, which is very important to control the complications. There are many advantages of osmotic technology, and because of these benefits, there is better adherence to anti-diabetic therapy, which is most important for preventing complications, and that reduces rate of complications and in turn decreases mortality and morbidity. we have with us today very eminent and learned faculty, Dr. Rajiv Kasliwal, Dr. C. Amrish, and Dr. Saul Jolly, to discuss regarding osmotic technology and how this controlled delivery system for anti-diabetic drugs is going to impact or change our diabetic practice. So, uh, I think we will update to a great extent with the deliberations of these speakers. So uh, over to Dr. Amrish for the next Dr. Amrish, to say something introductory remark. Thank you very much.
Thank you so much, sir, for sharing your views and setting up the ball rolling for this OSMO webinar. Uh, Coming to the second moderator for this particular OSMO webinar, we all know Dr. Ambrish sir from Bangalore. Sir is the consultant diabetologist. Sir is the investigator and the co-investigator for clinical research at Bangalore Clinisearch, and he has been the part of more than 20 clinical trials. Sir is also the chairperson of AC Ethics Committee Bangalore. Sir has been trained under Padma Shri Dr. Vimon. We all know him, and he has received a fellowship in diabetes from Dr. Vimon's Diabetes Center, Chennai. Dr. Amritsar has also been a speaker at various national, state, and regional level conference and has been associated with the several clinical trials and research projects. His key area of interest are young onset type 2 diabetes and gestational diabetes progression to type 1 diabetes. So with this, I welcome Dr. Amritsar and express our sincere thanks to him for accepting to be a moderator for this program and accepting to share his own experience related to the usage of these OSMO products in this webinar. Over to you, sir, for introductory remarks regarding this webinar.
Yeah, thank you. Thank you, Dr. Sahu and Dr. Parekh sir and Dr. Rajesh sir and all the delegates here. As we all know that the use of now insulin is almost like a decade, or sorry, century now, like from last 100 years. And if you look into the OHS, even metformin, we have been using it in the clinical practice for more than 60 years. And if you look into the essential drug list, metformin still plays a very important role as base for all medications. And even in Indian essential drugs also, WHO as well as Indian guidelines, that's the first essential drug which we look into in managing type 2 diabetes. If you look into just the prescription pattern of Indian doctors, more than 90% of the doctors advise metformin as the first line of drug, along with lifestyle and physical activity. And if you look into the European population, also European prescription pattern, more than 84% of the doctors still prescribe metformin. So that is the importance of metformin. So, but we still, when we are considering any oral hypoglycemic drug, we keep in few things in mind. That is like how effective it is in reducing blood sugar levels, whether there is any incidence of hypoglycemia, what is its concern regarding the weight gain, how affordable is it even after having all these issues, and does it address the pathophysiology. So metformin has all these issues in mind, but it has some constraint. So over a period of time, we will learn what are these constraints and how can we overcome with using OSMO safe technology. So that from this introductory words, I will complete my discussion. So over to Dr. Sahu.
Thank you so much, sir, for nicely explaining the background regarding conduct of this OSMO webinar. So, dear delegates, again, I welcome all of you for this today's OSMO webinar. And in next 10 minutes, I'm going to take you through the basics of the OSMO laser technology, which has been researched for the first time in India by Wockhardt Pharmaceuticals. So before I begin my talk, I request all of you, if you have any questions related to this OSPO technology and the usage of OSPO technology in the diabetes practice, I request all of you to post your question in the question and answer session or into the chat box. And at the end of the webinar, we will take all these questions during the panel discussion. So we all know that the immediate release formulations, they have certain limitations as far as the usage of these IR formulations in the clinical practice is concerned. Say, for example, the limitations are increase in the frequency of administration, decrease in the patient compliance, difficulty in achieving the steady state plasma concentration, and increase in the side effects because of the fluctuating levels of the drug in the blood. And therefore, recently a focus has been on the controlled release formulation of the drug. And we know that this controlled release formulation of a drug are capable of controlling the rate of drug delivery, achieving the sustained plasma concentration, and achieving the prolonged therapeutic action. Now we know that various control release formulation of drugs are available in the market, and all these control release formulation they use different technologies. So whatever the control release formulations that are manufactured by different manufacturing companies, they are using different technologies, and all these technologies used by the different companies they are not similar, they are different from each other, and therefore all these technological differences in the existing extended release formulation they result into certain limitations. For example, there is interference in the drug release by the pH and food. There is inconsistent release of the drug in the gastrointestinal tract, and all these things result into the unpredictable plasma concentration. And moreover, there is a chances of the increased side effects because of the increased dose dumping. So all these technological differences result into the different clinical outcomes. And therefore, to overcome these challenges of existing extended release formulation, a novel technology of drug delivery has been researched, which is called as the OSMO technology, which stands for osmosis mediated oral drug delivery system technology. Now, there are different advantages which OSMO technology offers. For example, the drug release is independent of the motility, pH, or food. And this particular factor is very, very important as far as the diabetes patients are concerned, because we all know that majority of the diabetes patients they suffer from the gastroparesis some or other time. Secondly, it also provides a delivery rate of zero order. That means a constant amount of a drug is eliminated per unit time. Thirdly, we can manipulate the rate of delivery. We can delay it, we can pulse it as and when required. It achieves a higher and predictable release rates, and there is a high degree of in vivo in vitro correlation. So how this osmo laser technology works? It basically works on the principle of osmosis, which is nothing but we all know a net movement of water across the semi-permeable membrane, which is driven by a difference in the osmotic pressure across the membrane. Now, if we look at the structure of the osmo laser tablet, we can find that there are multiple layers in the osmo laser tablet. The outermost layer is the I'm just using the pointer here. The outermost layer you can find here is the layer of a drug. Inside this outermost layer of a drug, there is a green color you can see is a semi-permeable membrane through which gastrointestinal fluid enters into the tablet. Now inside this green layer semi-permeable membrane, there is another layer of a drug which you can see in the light blue color, and inside that drug level you can see the brown color which is a push layer. So what happens when a osmolaser tablet is consumed by the patient, when it comes in contact with the gastrointestinal fluid, this outermost layer of a drug, it gets dissolved rapidly, and the absorption of the outermost layer of the drug starts. Also, parallelly, the water, the gastrointestinal fluid starts infiltrating, or the osmosis occurs through this semi-permeable membrane, and this push layer starts getting swollen. And as this swells, there is a generation of the osmotic pressure which pushes this inside layer of the drug through a laser drill hole in the center of the tablet. And in this manner, as the osmotic pressure gets generated, a drug is released through the tablet in a controlled way for a prolonged period of time. So this is how a osmo laser tablet functions. Now, to explain this osmosis mediated controlled drug release, we have a small video of less than 1 minute. So I request my colleague to share this video.
Yes, doctor, I'll share. Yeah. Yeah, can you see it, doctor? Is it visible?
Yeah.
Okay, I'll play the video.
Often, the trust between the doctor and the patient is held by a small pill. Extended release tablets can nurture that trust, but there needs to be more. extended release formulations offer various benefits to the patients, thereby enhancing patient compliance. However, all these formulations are not similar because of different technologies used. These technological differences in extended release formulations may have non-uniform drug release, leading to unpredictable clinical outcomes. The major limitations of conventional extended release formulations are interference in drug release by pH, presence of food, and other physiological factors, dose dumping, unpredictable and poor in vitro in vivo correlations, side effects due to fast release of contained drug, and local irritation or damage of epithelial lining. To overcome these challenges of extended release formulation, Wockhardt proudly introduces OSMO, Osmosis Mediated Oral Drug Delivery System technology. Push-pull osmotic pump is an advanced controlled release oral drug delivery system in the form of a multi-layered rigid tablet with an overcoat of the drug. Within this overcoat, there is a semi-permeable outer membrane, and within this outside membrane, there's again an inner layer of the drug. The inner layer has two parts, a layer of drug and one push layer that's composed of a swellable polymer material. Additionally, there are one or more small laser drilled holes in it for the release of the drug. As soon as the drug comes in contact with the gastrointestinal fluid, the outer layer of the drug dissolves quickly, giving a rapid initial release of the drug. Later, osmosis occurs across the semi-permeable membrane and water permeates inside the membrane at a controlled rate. As the water is absorbed, the push compartment expands. It pushes the drug towards the precisely engineered laser drilled hole. The drug moves outside slowly over a course of 24 hours in a controlled way. There are distinct advantages of OSMO. Drug release is independent of motility, pH, or the presence of food, provides delivery rate of zero order, achieves higher and predictable release rates, and can be pre-programmed with high degree of in vivo in vitro correlation. OSMO, Osmosis Mediated Oral Drug Delivery System Technology from Wockhardt Pharmaceuticals, reinforcing trust with technology.
Thank you, Priyanka.
Yes, doctor.
So I will
Thank
continue
you.
with my presentation. I will just start sharing my screen. Yeah. So having understood this osmolaser technology and the benefits of osmolaser technology in terms of pharmacokinetic and pharmacodynamic advantages, what is there this osmolaser technology is going to offer as far as the diabetes practice is concerned? Now we will know that the glimepiride and metformin they have established place in the management of type 2 diabetes mellitus, and various combinations of glimepiride and metformin are available today in the market. Now, all these extended release formulations of the glimepiride and metformin, as I told earlier, the different companies are using the different technologies to manufacture the extended release formulation of the glimepiride and metformin. And these technological differences, as I told in my previous slides, result into the unpredictable clinical outcomes with increased risk of the increased gastrointestinal side effects. And therefore, this innovative osmolaser technology has been incorporated into the existing glimepiride metformin combination to achieve the prolonged glycemic control and to overcome the gastrointestinal intolerance with the metformin. So what this glimepiride metformin osmo release tablet is going to offer, because of the incorporation of this osmolaser technology into glimepiride metformin combination, there is predictable drug release, there is sustained plasma concentration for prolonged period, there is 30% lower Cmax. That means the drug exposure is very, very less with glimepiride metformin osmo tablet. And more importantly, there is a less chances of dose dumping. So all these pharmacokinetic advantages offered by osmolaser technology in the glimepiride metformin combination, they gets translated into the clinical benefits to the patient For example, there are less chances of the gastrointestinal side effects because of the lower Cmax and because of the less chances of the dose dumping. Also, there is a predictable drug release. Uh, there is likely chances that the clinicians may not be able to uptitrate the dose of the metformin because of the increased risk of the gastrointestinal side effect. But with this osmo laser tablet of glimepiride and metformin, because of the lesser chances of the gastrointestinal side effects, the clinician will be able to uptitrate the dose of metformin safely. Also, because of the sustained plasma concentration, there is a prolonged glycemic control, and all these factors result into the improved medication adherence. So, all these are the benefits offered by the osmo laser tablet of glimepiride and metformin. Now, lastly, coming to the end of my presentation, I would like to draw your attention to the recently published article in the International Journal of Research in the Medical Sciences, January 2021. The authors were Dr. Rajesh Rajput, Dr. Prasanna Kumar sir, Dr. D.S. Arya from AIMS Delhi, Dr. A.K. Das sir, Dr. Zargas sir, Dr. Tivaskar sir from Mumbai. So all these senior endocrinologists and diabetologists research this article and publish in the international journal. And if you look at what they all want to say about this OSMO technology, it is the most promising strategy-based system for the sustained delivery of the drug, and it appears to be a promising solution for the limitations of the conventional extended formulation, which we discussed earlier. And this novel OSPO technology offers distinct clinical advantages to the patients and type 2 diabetes mellitus by ensuring the predictable therapeutic plasma concentration, resulting into lesser side effects and provides prolonged duration of action, thereby improving the medication adherence. So this is regarding the recent publication of the OSMO laser technology. So this is in short about the OSMO technology, the basics and its implication in the diabetics practice. And I request all the audience, if you have any questions related to this OSPO technology, please put your question in the question and answer tab or in the chat box. We will take all these questions at the end of the presentation by Dr. Kasliwal sir. Moving to the second part of this OSMO webinar, we are honored to have with us Dr. Raju Kasliwal sir. Sir is the senior endocrinologist from Jaipur. We all know Dr. Raju Kasliwal sir. Sir has been the integral part of initiating and furthering the 3 national level projects on the genotype phenotype correlation in Asian Indian patients. Um he has a deep interest in the clinical research and published more than 25 articles in the international and the national journal. He has also presented several posters in the international conferences and the symposium. Sir has been the speaker at various national, state, and the regional level conferences. Dr. Kashyap sir is also associated with several clinical trials and the research project, and his area of interest are basic research for improving the patient care, molecular endocrinology, and neuroendocrinology, especially the adrenal disorders. So with this, I welcome Dr. Raju Kasliwal sir and hand over the session to him for his talk on the challenges in metformin. Over to you, sir.
Yeah, thank you very much for your kind introduction. So, you are going to share my slide, right?
Shall I share, sir?
Or yeah, or I should.
I will share, sir.
No, I'm sharing it then. Fine.
Okay.
Good evening, everyone. So, we have learned a lot till now from Dr. Is about what are the advantages of having a good extended release preparation and how can it benefit in terms of improving the adherence. I think I am going to discuss a little more about it, and the technological part, how this Osmo technology does its job. That has been very beautifully shown in that video. So what is the basic problem? Why that there is a need for using this extended release, preparations, and how these extended release preparation, especially with newer technology like this, can actually change the landscape and the management and the outcome of diabetic patients. So let's start with metformin, and as all we know that metformin is called as queen, or it always right at the top of the management of diabetes. Every diabetic patient is being started on metformin as a first line drug. So metformin plays a very key role, very central role in management of diabetes, and it remains till the end, even when patient is on multiple other drugs, even when patient is on insulin. So having in a good preparation of metformin, which is suitable for a diabetic patient, which is tolerable for a diabetic patient, is very important thing. So initially, when metformin was present, or it was available only in the immediate release preparation, there were a lot of issues, and those issues basically we all know that they are almost all related to GI side effects, and the incidences of side effects, they are really actually high if we ask our patient carefully, or very if we ask them, give them a time and then ask about the problems. The diarrhea or the dyspepsia, the figures can go as much as high about approximately 50%. So this like diarrhea can go in sometimes, not everywhere, not every, there are different studies that quoted different figure, but what I can say, the overall the average comes around somewhere between 30 to 50%, which includes diarrhea or nausea or anorexia or dyspepsia or bloating like sensations. So almost we talk about take about single one single complaint of the GI symptoms. Almost 50 to 70% of patients at least have these complaints to sometimes maybe first 1 or 15 days, 20 days, or in a month or so. Later on, some of them develop tolerance to these side effects. So uh, ultimately sometimes it has happened practically also with all of us that yeah, the side effects is sometimes the adverse effects or side effects of these metformin is so much that sometimes patient discontinue the treatment, or just we ask them to follow up after a month or so, and they just land up on fourth or fifth day. Okay, doctor, this tablet is not being very friendly to me, and I have having so many problems, and I have stopped eating. My appetite has gone down, or I was always like nauseating and just about to vomit. So what ultimately it leads to, it leads to either discontinuation of the drugs, or sometimes when we try to optimize the dose of metformin, starting from anywhere from 500 to 1 grams per day, to when we want to go to 2 grams, or to the dose, it is difficult. And believe me, very I think a very few percent of patients actually tolerate our full dose of metformin comfortably. They will always have one or other problems. They'll take a lot of time to accept it, to these higher doses of metformin. So there is always difficulty in up titration, which ultimately, and there is a poor adherence, which may sometimes leads to discontinuation. We need to stop metformin at all, and ultimately all these things leads to poor glycemic control, because so or we may need to go to some other molecules leaving metformin. In fact, metformin is the first drug which we should try because of so many other benefits metformin provides to a diabetic patients. And this is a study again analyzed which analyzed almost 16 lakh patients, and out of what this study have shown, it was published in Diabetes, Obesity and Metabolism in journal. Almost 30% of patient one or other times try to not to take metformin because of some one or other side effects during their whole treatment period. So and it in fact in this study, the metformin was the drug which was most commonly discontinued compared to any other drugs because of this adverse or this side effect profile. What happens because of the side effect profile, patient discontinue the drugs, and because of this non-adherence, as all we know that adherence is very important, compliance is very important whenever we are dealing with a chronic condition like diabetes, which requires lifelong administration of medications. Multiple other pills are also going on. So it ultimately leads to inadequate glycemic control, which further leads to increased morbidity and mortality, and ultimately it leads to more and more hospital admissions because of the complications, more cost, both inpatient and outpatient, and then it requires more and more resources for management of complications. So and because of this non-adherence, which is such an important issue in a disease like diabetes, almost or almost 50% of patients do not achieve good glycemic control just because of their poor adherence. If they take their medications properly on time, I think this figure of this figure of good glycemic control, which we have around 30 to 40% in our general population, can go much higher. So this is just again just to show the importance of non-adherence in diabetes, like mortality. The risk of mortality and cardiovascular diseases or all-cause hospitalization can go significantly, almost all by 40 to 50%, like risk of stroke, nephropathy. So both microvascular complications and macrovascular complications ultimately increases to a very significant extent if the patient is non-adherent to the treatment and if the glycemic goals are not achieved in our diabetic cohort. So this is just based on, this data is based on National Health and Wellness Service of around 1100 patients, where what they have tried to see that what happens if each, they have devised a scale, and then one point for each point they have tried to quantify the adherence, and they try to correlate the adherence of medication with rise in HbA1c. So each 1 point drop in self-reported medication adherence was associated with 0.21% rise in HbA1c, 5% almost increase in physician visit, more than 20% rise over a period of time, not immediately, but over a period of time, in emergency room visits, and or almost 20%, again 21% times more and more hospital visits. So how an adherence issue like an adherence or compliance to the drugs can ultimately it leads to rise in HbA1c, and which ultimately leads to increase in the complications, that is being shown in this survey. Another paper again published in Diabetic Care in 2012 is like impact of treatment of non-compliance on mortality in people with type 2 diabetes. Again, it's a 15,900 patient study, and what this study have shown that the sheer impact of non-compliance, not about the drug what they are taking, that's just non-compliance to the existing treatment, increases the hazard ratio by almost 57%. This is like almost 1.6 fold increase in all cause mortality. So improved how does the improved medication adherence can help us? So each 10% increase in compliance reduces the HbA1c of around 0.14, and which can ultimately over a period of time, over a throughout lifespan of a diabetic patient, can cut down the healthcare cost by almost around one third, 30%. And the complications rates and the various mortality and CV death figures also goes down if the compliance improves. So high level of adherence is as effective as actually adding an another or second line anti-hyperglycemic drugs, and that is what practically sometimes we see also. Sometimes in our busy practice we forget to ask how much compliant the patient is towards the existing drug or the first drug. And because the figure we see the reports, the sugars are high, HbA1c high, and we tend to add the second drugs. But practically, in fact, and ask history in a more closer way, then patient sometimes reveals that he is missing drugs 4 or 5 or 6 times or 7 times in a month. So that is what it is being shown, that if we try to improve the compliance, the need for addition of another drug or second line drug, or when patient is already on second two drugs, then third line drugs, that need may be reduced to a significant extent if the compliance can be ensured, the 100% compliance. So what is the solution for this thing? I think technology like OSMO laser is a very promising strategy based system that has already been discussed. And basically, I am not going to into detail. This has already been discussed by Dr. Earlier Dr. Speaker. So this technology, if that can leads to lesser and lesser side effects and lesser GI side, which can improve the adherence, I think nothing is better than that. This is where I am going to end. And what I mean as a practitioner, I think metformin and is a very important drugs, and this technology has played a very important role in improving the adherence. of drugs like a metformin by providing the sustained release of molecule by improving the acceptability to that patient, and ultimately by improving their glycemic control and the complication rate. And if the same principle and same technology can be applicable to other drugs also, I think the life of diabetic patients can be a little more easier, which is already difficult, especially in later part of the day when patients are on multiple drugs. I think I'll end it here, and we will discuss if there are some comments and points at the end.
Thank you,
It's
sir.
over to you again. Yeah.
Thank you so much, sir. Can you just unshare your screen so that I can start my screen, sir?
Just a second. Yes.
Thank you so much, sir, for such a elaborative talk on the challenges of metformin in the clinical practice with respect to the gastrointestinal intolerability and sharing so much of our data that is available related to this issue. So thank you so much. So coming to the last part of this OSMO Wow webinar, we are honored to have with us, as I told, Dr. Amrish sir from Bangalore. Sir has been a part of the OSMO Safe study. So this OSMO laser technology, since it has been introduced, a lot of studies are ongoing and some of the studies have already been completed. So one of the studies that we are doing is the OSMO Safe study, and Dr. Amrish sir has been an investigator for this OSMO Safe study. So we'd like to know from Dr. Amrish sir how has been his experience as far as the usage of these OSMO products, particularly the glimepiride and metformin, in his to diabetes patient circles. Dr. Amrish sir.
Yeah, thank you. Thank you. Okay, I was fortunate to be a part of this osmosis study, which was basically a prospective, open label, parallel group clinical trials, which had glimepiride plus metformin with the extended release formulation with glimepiride either 1 mg or 2 mg with metformin of 500 mg. And the other arm was glimepiride with metformin. Metformin was around 1000 mg and glimepiride 1 or 2 mg using OsmoSafe technology. So there are two arms with these. One is with OsmoSafe and one is extended release. So what was the primary objective of the study was to look into the gastrointestinal side effects. What was the common presentations what we have with the metformin? That is abdominal pain, any diarrhea or nausea, vomiting, dyspepsia. So any of these symptoms was the primary objective was to look into these issues. And the end product was to look into the gastrointolerance during the 4 months. Basically, the study duration was 4 weeks after giving this medication in different groups. And then looking into the overall, gastrointolerance with these patients. And was there any requirement of discontinuation of medication or how many patients developed this side effect, gastrointestinal side effects was as the end point of it. The inclusion criteria was any patient that I was newly diagnosed type 2 or who was already on medications with glimepiride or metformin with the age group of more than 80 years and with the HbA1c of more than 7.5 or less than 10.5 were considered to be as an inclusion criteria. So these patients were taken and randomized into two different arms and followed after 4 weeks. So what we found in this study duration as a complaint, still the data analysis is be done. But from as a clinician, what I have seen is definitely the acceptance of metformin, even though it was 1000 mg with OsmoSafe, still they didn't have any issues or any difficulties in swallowing the tablet or any gastric intolerance issues, which was a common presentation with metformin. Thank you.
Okay, thank you so much, sir, for sharing your experience in actual clinical practice, how these OSMO products, the glimepiride and metformin combination behave, and how they have reduced the chances of the gastrointestinal side effects of metformin. So thank you so much, sir. Um, Okay, doctors, apart from these OSMO products, which OSMO technology, which we have incorporated into the glimepiride metformin combination, we are already utilizing this OSMO laser technology in the other available anti-diabetic medications. So there is the pipeline for this OSMO product is very strong, and I'm glad to share with you that this OSMO laser technology has been introduced for the first time in the world in vildagliptin. So we all know that vildagliptin, it has established place in the management of type 2 diabetes mellitus. And if you look at the dosing pattern of vildagliptin, it is the only DPP-4 inhibitor which is to be given twice a day. So it has to be given 50 milligram twice a day. However, there is one subset of patients wherein we need to give vildagliptin 50 milligram once a daily. These patients are the patients with moderate to severe renal impairment or end stage renal disease, and those patients who are on already on the sulfonylurea. So this subset of patients we need to give vildagliptin 50 milligram once a daily instead of twice a daily. So if we give once a daily 50 milligram vildagliptin in this patient, there are likely chances that the DPP-4 inhibition that is going to be there with once a daily tablet will last only for the 12 hours. So there is a sub-maximal DPP-4 inhibition with once a daily 50 milligram vildagliptin, and therefore there is the patients who have been treated with once a daily vildagliptin 50 milligram, they will be deprived of the prolonged DPP-4 inhibition because they will get the DPP-4 inhibition only for the 12 hours, and therefore considering this particular fact, this OSMO laser technology has been incorporated into vildagliptin, and it has offered in a such a way that the vildagliptin is released in a sustained manner so that the DPP-4 inhibition is extended for a period of 20 hours as compared to 12 to 13 hours with the conventional vildagliptin immediate release formulation that is available. So if you want to give 50 milligram once a daily to your patients instead of 12 hours DPP-4 inhibition, osmovildagliptin, that is obiltaloc, can give you the DPP-4 inhibition for almost 20 hours. So this will not compromise the prolonged glycemic control. Not only this, we have also incorporated this osmolyzer technology into vildagliptin 100 milligram because we all know that vildagliptin is given twice a day, and therefore there are chances of decrease in the medication adherence because patient has to take multiple tablets, patient has to take a twice a daily regimen, and patient is already on the multiple drug therapy. So what we have done, we have incorporated this osmolyzer technology into vildagliptin 100 milligram. So the DPP-4 inhibition that is achieved with vildagliptin 100 milligram is almost 23 hours, whereas with twice a daily regimen we can get 24 hours. So similar to twice a daily regimen, we can get 23 hours DPP-4 inhibition with just one single tablet of vildagliptin 100 milligram. And we hope that with this it will definitely improve the medication adherence, and thereby it will also improve the glycemic control. So these are the two products which are in the pipeline. Apart from these two products, vildagliptin 50 milligram and vildagliptin 100 milligram sustained release, there are multiple products which are in pipeline wherein we are incorporating the osmolyzer technology with distinct clinical advantages to the patient. So with this, we will come to the last part of the presentation, which is the panel discussion. And we are honored to have with us the esteemed panel of Dr. Ambrish sir, Dr. Parekh sir, the senior diabetologist, and Dr. Rajiv Kasliwal sir. We will take the questions one by one from the audience. I request all the delegates, if you have any questions related to this OSPO technology and its implication in the diabetes clinical practice, please type your question in the chat box. So before we take the questions from the audience, I would like to ask the first question to Dr. Rajiv Kasliwal sir. Sir, you have shown a lot of data related to the gastrointestinal intolerability with metformin, and so much of the studies have already been done. So, what is your own clinical experience as far as the usage of metformin is concerned, and how much is the burden of gastrointestinal intolerability in the actual clinical practice?
So as actually I've said and during my discussion also, okay, I think starting metformin, patient may accept it. Then there are always exceptions. Some people even don't even tolerate 500 milligrams, or but generally over a period of time, most of the people tolerate 500 BD, easily. In fact, 1,000 milligrams per, once a day is also giving it is also a challenge. So and it happens very rarely that at least that patient tolerate 1 grams twice a day without any complaints. Yeah, there are proportion of patient where the acceptability improves over a period of time, but it has happened so many times in like in my own practice that people do not tolerate 1000 milligram BD, whether it's alone or in combination with other drugs. We have many times reduced the doses back from 1000 BD to 500 BD, which should not be the case. Actually, optimum dose is 2002 grams at least a day. So I don't think so. I think it's not a very uncommon scenario. That intolerability to metformin is very, very common. And if we ask carefully, most of the patient report one or another gastrointestinal side effects. The figure may go high as 50 to 60%. It depends how keenly or how you ask these questions to the patients about these side effects. So it's all about eliciting the history from the patient.
Yeah, yeah, very true,
A
sir.
very practical issue. Yeah.
Yeah, so you have pointed out a very important point here, sir. As we are not probing into the patient whether you are suffering from the gastrointestinal side effects in daily clinical practice, maybe the burden that we are seeing today in terms of the available literature, the actual burden may be much higher than the literature that is telling. So coming to this particular point, I would like to take this ahead and ask Dr. Parikh, sir. Sir, we know that majority of the patients may not get the required A1C control with 500 milligram or 1000 milligram, and there is always a need to up titrate the dose of metformin in majority of the patients. So, having understood the challenge of the gastrointestinal intolerability with metformin, how difficult it is to up titrate the dose of metformin in the daily clinical practice? Parikh, sir.
We know that metformin is the number one drug which is being sold maximally worldwide, and it is after lifestyle modification, it is the first drug to be used for diabetic patients. And the maximum doses, which Dr. Kasliwal said, even up to 2500 milligram can be given, and we must give advantage, maximum advantage to the patient or for the metformin, because it is one of the drug which helpful to a great extent in decreasing weight, in cardiovascular protection, so many uses also. So the tolerance is very important. As Dr. Kasliwal said, that we usually do not ask the patient that whether you are tolerating the drug or not. And many times, even if the patient says, we don't give much attention because of lack of time or because of lack of communication. This is what I usually see in our practice. So this becomes, until unless patient gets that he cannot accept, and then he becomes rigid that I can't take these tablets. So that is the big problem. So I think this is the right way. If we bring a smaller tablet, which is acceptably gastrointestinally, it is friendly to the gastrointestinal tract, and it is, I don't think what is the difference and what is the implication of the cost after osmotic technology. But I think it is a revolutionary thing. And as you said, it has come in the metformin, it has come in the glimepiride, it has coming, you have brought DPP-4 inhibitor, which a drug which we can just close our eyes and it is such a safe drug that we can close our eyes and write a prescription to the patient. There is no chance of hypoglycemia. And I do not know how OSMO technology can be used for SGLT2 inhibitors, because it is a very important drug which is coming and becomes very, even it has gone on the first line by ADA and ESD and all these things. So I think this is definitely going to impact the diabetic practice to a great extent. These OSMO technology and bringing a small and a GI friendly tablet of metformin.
Thank you so much, sir. Warik sir, before I take the questions from the audience, I would like to ask a last question to Dr. Ambrish sir. Having understood that there are challenges of gastrointestinal side effects with metformin, and we know that diabetes being a chronic disorder, majority of the patients may not adhere to the prescribed medication. So there is always a challenge of medication non-adherence. So how difficult it is to achieve the A1C control if the patient remains non-adherent to the prescribed medication because of any reason, and what solutions to find out in the daily clinical practice?
Yeah, definitely it was one of the common things. If you look into the average HbA1c of Indian population, so as I told you, so it's around 8.4 or 8.5. Even with insulin or with almost around say 8 to 10 groups of OHS present in at present clinical scenario, still the average HbA1c stays around 8.4. So that is mainly because of the kind of lifestyle and as well as the medications what the patient is not adherent to. So as you told, definitely one of the presentations also we have shown that instead of just going to 2, 3 medications or OHS, adherence to a particular drug itself will have a better scenario, better clinical effects will be seen. So metformin definitely is one of the commonly used drug as a baseline drug, as I told you. So what are the common causes for discontinuation of metformin? One is that complaints is that gastric intolerance, and second one is the vitamin deficiency, vitamin B12 deficiency, neuropathy, UHC. So most common is the gastric intolerance. So starting off with very small doses of metformin if the patient is not adherent to, say putting back to even 250 mg, starting with the sustained release medications. These are some of the things where we can look into and add on to other, as I told you, when metformin patient is not able to tolerate, then we have to look for other alternatives like DP4 inhibitors or SGLT2 inhibitors to bring down the blood sugar levels in good control. Or if the patient is willing and the HbA1c is really more than 8, 8.5, then going with insulin also should make a better option in these scenarios.
Okay, thank you so much, sir. So I will move on to the questions from the delegates, and if these questions are related to the OSMO technology, I would like to answer those questions. And if these questions are related to the clinical practice, I will request Dr. Parekh sir, Dr. Kasliwal, and Dr. Amri sir to answer these questions. So coming to the first question, which I can see in the chat box, is from Dr. Dilip Vijay Varghia. Dr. Dilip is asking how is the OSPO technology different from the pattern release and the other release preparations? So, Dr. Dilip, as I told in my presentation, different companies are using different technology. So, if you look into the details, it is mostly a gel-based technology or matrix technology that other companies are using, which is completely different from the OSMO laser technology. And we have seen that when we compared these technologies with the OSMO laser technology, the osmolar technology has an upper hand because it is dependent upon the osmotic pressure that is being generated. So it, as it works on the principle of osmosis, it has a number of advantages which I just told in my presentation, including the sustained release of the drug, achieving the therapeutic sustained plasma concentration, and prolonging the duration of action. So the osmolar technology is distinct from the technologies which are being used in the conventional extended release formulation. Coming to the next question from Dr. KP Jain, is it a fixed drugs combination? Yes, Dr. KP Jain, this is a fixed drug combination of glimepiride and metformin osmo laser tablet. As I told in my last part of the presentation, that osmo laser technology has been incorporated in vildagliptin as well, which is a monotherapy tablet. Coming to the next question from Dr. Subhash Gajria, what is the cost difference between SR and the Osmo release tablet? And Dr. Parekh sir was also telling about the cost differences between, because whenever there is technologies involved, there are going to be a lot of money involved in the research and development. So obviously there has to be a difference between the newer technology tablets versus the conventional tablets. So I request my colleague Priyanka, who is handling all the Osmo products, to throw a light on how the cost difference between the conventional extended release formulation and the Osmo release tablet.
Thank you, Dr. Shah. So as rightly doctor has mentioned that price is a concern. So we also agree with the doctor saying, because many times it happens that patients are prescribed certain medication, they don't continue because of the cost. So with this new OSMO technology, we have tried to ensure that the cost is not a hindrance for the patient and they continue the medication as per the prescription. So just to give you an idea on the cost part, sir. So Oglimade is costing similar to Glimade only. And if I compare with other brands also in the market, one tablet of Oglimade Port 1, which is the higher strength, is costing only 7 rupees 20 paisa per tablet. And the 1000 mg strength is costing just 10 rupees 20 paise. So we have tried to ensure that the patients are continuing the medication, and because of the cost, they do not stop the medication. So at Wokhar, that is our whole endeavor at affordability with best quality of medication. So I hope that should be able to answer the question from the doctors.
Yeah. Thank you, Priyanka.
Thank you.
So, yeah, so Dr. Subhash, there is no difference as far as the cost to the patient is concerned. Yes, there is difference between the development cost of the OSMO product versus conventional tablet, but that is not being translated to the patient. So there is no difference between SR tablet, OSMO, and the conventional extended release formulation as far as the patient's pocket is concerned. Coming to the next question, Dr. Ganesh Kumar. After completely release of metformin, what happens with the push layer? So Dr. Ganesh is trying to ask what happens to the push layer. As I said, there is a swellable push layer which generates the osmotic pressure after the osmosis. And this push layer is made up of the biodegradable product, that is cellulose acetate, and it gets digested within the gastrointestinal tract. Very rarely, Dr. Ganesh, this saleable push layer may come out of the gastrointestinal tract in the feces, but this is very, very rare, and that may take a shape of the tablet. And patient may feel that the tablet has come out, but that is the case with the all the extended release formulations that is available in the market. But the chances of this getting in the feces is very, very rare. Coming to the next question from Dr. Shalu Bhutani, stomach hyperacidity and diarrhea affecting this. I will partly answer this question and then I will ask Dr. Kasliwal to comment on this. As I said in my presentation, this osmolaser technology, the gastrointestinal motility has no impact as far as the release pattern of the osmolaser tablet is concerned, and therefore uh, I can say that yes, the gastrointestinal motility will not affect the release, will not affect the absorption of the glimepiride metformin in the stomach. Sir, Dr. Kasliwal, sir, your comment as far as these two disease conditions are concerned, stomach hyperacidity and the diarrhea, and the absorption or the effect on the metformin. Sir, you are on mute.
Yeah. Just a second. Fine. So as far as you said that with this technology, there is no effect of pH on the release of metformin. Uh, if the release is slow enough, which is not going to be irritating your GI mucosa, I think that should not be a concern. If patient is having severe acidity and his gastric mucosa is already been inflamed, so yes, there are always theoretical chances that metformin as a molecule has a property of irritating the GI mucosa and causing all these side effects. What we are doing with this technology is we are trying to slow the release or excessive release at one time, so the irritation of GI mucosa can go down. So yes, the patient who have an underlying hyperacidity, they are more sensitive. They may be more sensitive towards metformin side effects, but the incidence of these side effects are going to be much lesser with these kind of technology compared to when we are using immediate release metformin or for that matter other conventional extended release preparations, I think. So yes, there may be chances of intolerability or unacceptance in patient with underlying a GRD or acid peptic disease, but definitely the tolerance with these more this technology is going to be better than other one. That is what I can say.
Okay, thank you, sir. The next question is for Dr. Parekh, sir. Dr. Rajendra is asking, what is the ideal time of giving this combination of glimepiride and metformin to the patient? I mean, before the meal, after the meal, and at what time we should give this combination to the patient?
I think there is a problem of postprandial hyperglycemia. So I think the right time is before meals, maybe suitably 1 hour before meals, or if somebody forgets, then he can take before meal. And if he forgets, then he can take later on also. So I think because postprandial hyperglycemia is one of the biggest problem and one of the reason for uh, increasing HB1C also. So I think before meal, or if somebody forgets, then he has to continue even after the meals. I think what Dr. Rajiv says, just what is your comment, Dr. Rajiv?
Sir, just I think metform for metformin per se, it really do it's not of a great. I think it doesn't count too much that we take it before or after meal, because the pattern of action is metformin is different compared to a sulfonylurea, which is supposed to be taken before meal, because it has to go get absorbed and then get on the beta cell and then try to stimulate the insulin secretion. For metformin, because it works by inhibiting the hepatic gluconeogenesis and by improving the insulin resistance. So timing is not that important as it is in with sulfonylurea. And conventionally, actually, we have all been most of, I think, and I think sir will agree with me, because this tolerability issue, we have been asking patient to take metformin immediately or with the meal, so that the side effect issues goes down. Otherwise, patient can take it before meal, as especially with technology like this, where the release is slow and acceptability or GI side effects are low, then the metformin can be taken before meal. If at all some patient develop any kind of GI side effect, even with these newer technology or with other preparations, then before discontinuing or before decreasing down the dose, I think one should try to give them after meal. And after giving, at least in my practice, and I think Dr. Amrishan also can comment on this thing. The proportion of patients who were not tolerant to the drugs when they were taking before meal, that proportion goes much down when they take it after meal, immediately after meal also.
Yeah. Yeah, thank you, Dr. Rajiv. So definitely what you look into the technology, the glimepiride is immediate release and the metformin is sustained release. So it is ideal to give before meal. That will be taking care of both postprandial peak as well as the mechanism is taking.
I was just talking about monotherapy as a metformin monotherapy, not the combination.
The time
In
they
here,
combination, and usually they take combination. Hardly very few those who are on monotherapy.
Yeah.
Yeah, so just to highlight one more point here, even if we wanted to give this glimepiride for me combination after meal, as I told that the food will not interfere with the release or absorption of the glimepiride and metformin. Coming to the next question from Dr. Manna, is OSMO technology available for metformin without glimepiride? This is from Dr. Bhansali. So Dr. Bhansali is asking whether it is available in the metformin. Let me tell you that this osmolaser technology has been incorporated only in the glimepiride metformin fixed dose combination, and we have received the approval from the DCGA for India. However, when we started researching this osmolaser technology for the first time, we tried it in the metformin and we introduced this osmolaser technology in metformin, and we have introduced this osmolaser tablet of metformin in US. However, based on the usage pattern of Indian practitioners as far as the metformin versus combination is available, we took a business decision not to introduce osmolaser tablet in metformin monotherapy. And instead of that, because of the more usage of a glimepiride metformin combination than the metformin alone, we introduced this technology in glimepiride metformin combination for India. But yes, it is available and it has been tested and researched with the metformin tablet alone. Dr. KP is asking fixed dose combination only. Yes, it is a fixed dose combination. Has there is one more question? Has it been marketed, and what about the affordability? I think affordability we have already answered that question. And has it been already marketed? Yes, we have already marketed this glimepiride metformin osmorelis tablet, and I am also glad to share that we have received DCGI approval for vildagliptin 50 milligram and vildagliptin 100 milligram sustained release osmo tablets for the first time in the world. Metformin is well tolerated after meals. I think we have already answered that question. Uh, is generic metformin as effective as branded? I think whenever any generic product as such is marketed and they get the approval from the DCGI, there is no difference between the generic and the innovator product. However, as per the usage of the generic versus branded, maybe Dr. Ambrish and Dr. Kasliwal can comment on this as per the usage and the experience of the patient is concerned.
Yeah. Hello.
Dr. Ambrish, sir? Yeah.
Yeah. So if you look into the means any generic molecule, so they have to get a BAB study, means bioequality and bioequivalence study done. So if usually they compare with the research molecule and do it. If there is anything more than 95% of the drug concentration, then usually it passes the DCGI query of give that. So if you look into the molecule was associated, so definitely it should have the similar effect. But company to company, these variations may happen, and the composition of the drug, the release pattern, all those things will be different. So even those things can affect the composition, the content, the binding materials, what they use. Recently, we came up with the issues with metformin tablets for having carcinogenicity. So because of the some binding factors, all of that. So even those factors can have a effect on generic as well as for means if you see both will be equal, but depends upon brand to brand, some variations may be there.
Okay. Thank you so much, sir.
Dr. Shah, Dr. Sushil Kelly wants to share his feedback. So if you allow me, I can, put him in the panel. That's
Okay,
okay.
please transfer him to the panel. Dr. Sushil Kale.
Yes, I have added him to the panel. Dr. Sushil Kelly.
Welcome, Dr. Sushil. You want to share something? Dr. Sushil, can you unmute yourself?
Am I audible?
Yeah, Dr. Sushil, please go ahead.
There are three questions about the metformin. One is that why there's a less lactic acidosis. This is one. And secondly, and why there is no hypoglycemia in non-diabetic and pre-diabetic patient. This is second. And third is the effect of GLP-1 and how it works as a anti-oncogenic and anti-aging metformin. So the answer to that is latest developed by the Mayo Clinic, Dr. Nair, in an international forum. His observation and studies, I'll just take 2 minutes. I'll cover them 2 minutes, right?
Okay.
So one is that why there's a less active lactic acid in metformin. It has got the 20-fold less as compared to the fenformin, and the underlying factor is less powerful inhibitor of the mitochondrial respiratory chain. Probably this is the main reason or decreased risk of lactic acidosis. So this has been highlighted. It has got the less powerful effect on the mitochondrial respiratory chain. So that's why the lactic acidosis is less. And second, how it works as anti-oncogenic and anti-aging, this has been highlighted by GDF 15 factor, growth differentiation factor 15. So this is expressed in concentration most of the organs because of the injury to the organs like kidney, heart, and lung. So to prevent that, it binds to the receptors GFRL, that is GDNF family receptor alpha-like uh, uh, receptor, and it activates the GFRAL expressing neurons, promotes weight loss. So this has been studied in the mice. So it promotes the growth. That is by virtue of that, there is anti-oncogenic and anti-aging phenomena. And the last one, why there is no hypoglycemia and in pre-diabetic and non-diabetic patient. That is the GLP-1 effect has been highlighted by virtue of when there is hypoglycemia, the glucagon increases, insulin comes down, and when there is hyper, it is vice versa. So the GLP-1 effect has been also highlighted. These are the three latest observations, recently updated by Nair and Mayo Clinic, an international forum.
Okay, thank you, Dr. Sushil, for sharing such a nice information. Keeping in mind the time that we have, maybe we can take another couple of questions and then we will close this meeting. Um, there is one question from Dr. Akil as well as Dr. R.C. Chaudhary is asking, what about vildagliptin 100 milligram in hepatic impaired patients? So we all know that there is hepatic concern with vildagliptin, whether it is 50 milligram twice a daily or vildagliptin 100 milligram once a daily. And we all know that vildagliptin 100 milligram is not marketed because of the hepatic concerns. But let me tell you that as we have introduced this OSMO laser technology into vildagliptin and we have achieved the sustained plasma concentration, lower Cmax, lower drug exposure in the patients, we have found that when we did this PKPD study with vildagliptin 50 milligram as well as vildagliptin 100 milligram, we found that a couple of patients, they have increased levels of AST and ALT. However, when we tried to find out the statistical significance, it was not significant because basically it was not more than the 3 times the upper limit of normal. That is the criteria that is basically used, whether it is crossing the hepatic enzymes are crossing the 3 times of the upper limit of the normal, but it was not seen in vildagliptin OSMO release. And there is obvious reason for that. There is a less drug exposure, there is a lesser Cmax that is achieved with the sustained release of the OSMO vildagliptin tablet. And therefore, we are expecting that hepatic concerns will not be there with vildagliptin 100 milligram. However, we are starting some studies to assess the hepatic safety concerns of the vildagliptin 100 milligram. Similar questions are coming from related to the cost. Maybe we can take the last question. Verified trial suggests the usage of combination of metformin and vildagliptin, initial drug in most of the Indian patients. Yeah, this is a question from Dr. Subhash Gajre. Yes, Verify clinical trial definitely has shown us that the initial combination therapy is much, much better than the stepwise addition of the oral hyperglycemic agents. And in this particular clinical trial, vildagliptin metformin was used as an initial combination therapy. So before we end this meeting, I would like to know from Dr. Parekh sir, Amrish sir, and Dr. Kasliwal sir, in sequence about their clinical experience as far as the initial combination therapy versus stepwise addition of the oral hypoglycemic agent is concerned with respect to vildagliptin and metformin combination. Dr. Parekh sir.
Combination therapy, I think, because aggressive and initially we must give aggressive therapy. We know that after HB1C 7.5 gram, 7.5, we must start monotherapy, and then later on we can start, if it is more, then we should start combination therapy, because once you start on monotherapy, then you escalate, and then you start combine the therapy. There is a lot of legacy effect of monotherapy. So I think the combination therapy and the Verify study also, as you already said, that it is proved that combination therapy is much, much better as compared to monotherapy. And the recent ADA guidelines and ASD guidelines does also say that even in some conditions, initially you can start on combination therapy. So I think you just can wait for 4, 5, 6 months for monotherapy, and then you can start with combination therapy. Or the latest trend is to start combination therapy initially to control the hyperglycemia and to have better legacy effect, because the duration of hyperglycemia definitely increase risk of complications.
Thank you, sir. Dr. Amrish, your thoughts on this?
Yeah. I was a part of Verify study as an investigator. So what we looked is initially, as I told, we had a combination of metformin with vildagliptin. But when the HbA1c was more than 7 for continuously more than 2 continuous visits, then we had to put the patient on insulin. So that was the thing where we had looked into. So in earlier intention, the same is that the earlier you get the things in control, there's less chances of the patient progressing into complications. That was the idea behind the thing, and putting back things under control. So, but definitely when you look into combination for vildagliptin and metformin in newly diagnosed patients, so the control is better, the complications, patient going to complications is less, adherence to medication is better because of single tablet has this combination. And even if the patient is required, it all depends upon the requirement, comorbid conditions of the patient. If the patient comes with a newly diagnosed patient with more than HbA1c of 10, I don't mind starting off even insulin. Okay, so it all depends upon the comorbid conditions, patient, other things also we have to keep in mind while taking decision. Definitely starting off with all the studies like Wikipedia as well as DCT studies have shown earlier control better for the subjects. So keeping that in mind, whatever is the requirement, whether it is SGLT2 inhibitors or DP4 inhibitors or any combination, even as sir told, all the recent guidelines since if the patient is already having comorbid conditions like cardiac and renal failure, then think about SGLT2 inhibitors and GLP-1 locks as a first line of therapy. So those things should not be any interference in thinking of with combination.
Dr. Rajiv sir, what's your take on in which subset of patients you would like to go for the initial combination therapy?
I think that till now what the guideline says that whenever your HbA1c is more than 1 to 1.5 percent from your target HbA1c, you should directly go for a combination therapy, because it's very difficult to get that kind of reduction in HbA1c with a single drug. So that is what the guideline says. And then there are practical issues now. In fact, the strategy of treating diabetes has changed. We now go for more of a pathophysiological basis of treatment of diabetes. So more mechanism of pathophysiological mechanism we can target, I think better it is going to be in a long term basis. So that is why if we use in a combination, probably we can address more and more pathological mechanisms. And maybe that is one of the reason, that's still a part of a research we need to do, why this combination of vildagliptin and metformin ultimately resulted into more sustained control when it was used as a combination from the beginning rather than being used in a stepwise manner when we use Vilda once the one drug has failed, rather than using them together from the beginning, hit hard from the beginning. So that may be one of the reason why the ultimately the secondary failure rate for vildagliptin was lesser with the combination therapy. And then the practical issue comes always that if you start, wait for one drug to fail and then add another, there is always a lag period in between, which lag period may be because of physician inertia, which we talk about in all the conferences, or it may be because of the patient do not land up with a doctor. Sometimes they take time, 6 months or 1 year before that they try to contact the doctors for change in prescription. So ultimately, what is this leads? It leads a significant glycemic load which accumulate during this period where the intensification has not been done. And by using combination, I think we can avoid that additional glycemic exposure, which over a period of time, it may not be look important in during that short period of first 1 or 2 or 3 years, but over a period of time, this glycemic overload during this lag period or this lag phase between intensification amounts a lot and ultimately contributes significantly to the overall complication. So I think using combinations is the way forward probably, and ultimately it cut down the pills also, number of pills. So I think all these things favors, and probably with a, since the data from Verify trial, I think came the results came 5 year down the line. So whether what are we going to see, and ultimately what we will see, whenever we started combination, we will see the results after 5 years. So saying that my patient have done well on combinations in terms of endpoint, I think it's too early for me. But the logic, whatever is being given, I think it looks sounds, and the reasons behind why it happens appear sound. So there is no harm in trying this thing, and probably we will reap these benefits over a period of time, maybe 5 year or 10 year down the line. Thank you.
Thank you so much, Raju sir. There are many unanswered questions in the chat box, but keeping in mind the time, we will not be able to answer these questions. But let me assure that we will answer all these questions offline. Multiple interesting questions are coming from the audience, whether we can extend this osmo laser technology to antihypertensive and to other OADs like SGLT2 inhibitors. Let me tell you that we are getting multiple requests from various pharmaceutical company to outsource this to give this osmolyzer technology so that they can incorporate into the other therapy as well, including the antihypertensive. We are currently working on that, and for other other OADs like SGLT, we have not yet evaluated for that. Currently, our focus is on glimepiride, metformin, vildagliptin, and yes, there are some other molecules on which we are focusing because we need to get the benefits if we are incorporating this technology, not just for the sake of introducing. We will not be interested in that. So yes, we will keep you updated regarding what all products are coming up with the osmolyzer technology. So coming to the end, the last part, I request our National Sales Manager, Mr. Pradeep Nigok, to give the vote of thanks.
Thank you, Dr. Sahu. So, good evening, everyone. It was my pleasure to pay a vote of thanks for today's WOHAD OSMO webinar. We call it WOW webinar. So, the makers of O-Glimade and O-Vildalag. It was a very nicely and well presented session. My heartiest thanks to today's respected faculties, Dr. K.K. Parikh sir, Dr. C. Ambarish sir, Dr. Rajiv Kasliwal sir, and Dr. Sahu Ingole. My sincere thanks to all the attendees of today's webinar. I also thank Priyanka for successfully organizing this meeting on WOW. And my sincere thanks to our AVP, Mr. LCS Sri Vishnu sir, and President Dr. BGS Gupta for guidance and support. My thanks to WOHAD colleagues, Mr. Mahendra Sagu, Kendesami, and Aditya Mahajan, and entire diabetes and metabolics team and their leaders for nicely coordinating with all the delegates in making this symposia successful. Thank you all again and have a nice evening.
Thank you so much, sir.
Thank you, Dr. Parikh sir, Dr. Amrish sir, Dr. Kasliwal sir. Thank you so much.
Thank you. Rajiv, Amrish, thank you.
Thank you.
Thank you, Rajiv sir. Thank you, Amrish sir.
Thank you so
Bye.
much,
Good
sir.
night.
Thanks a lot. And thanks for sparing your time. Thanks a lot.
Thank you, sir.